Good evening, everyone. Thank you for joining us tonight, and welcome to the Dementia Medical Update. This is a Chris O'Brien Lifehouse CPD series presentation. My name is Lydia Koenig. I'm a CPD Program Officer at the Central and Eastern Sydney PHN. And also working with us tonight, Lauren Thomas, my colleague from CPD, and who is Antenatal Shared Care and CPD Program Officer as well. Before we begin, I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognize the continuing connection to waterland and community and pay respect to elders past, present and emerging. I would also like to extend that respect to Aboriginal and Torres Strait Islander colleagues who might be joining us tonight. I would also like to warmly welcome our GP chair for this event, Dr. Peter Piazza, who is a member of advisory committee for the CPD GP education in the Inner West region. But before we move on to our presentation, I would like to invite Dr. Martina Gleeson. Dr. Martina Gleeson is Clinical Lead General Practice Southeastern Sydney HealthPathways and also Regional Clinic Advisor HealthPathways New South Wales. And Martina will give us an update on HealthPathways in neurology and dementia. Thank you very much, Martina.
Thanks very much, Lydia. And thank you everybody for giving me just a little bit of your time for this. There's been a few changes in HealthPathways, so I thought it would be good to give you an introduction. Many of you would be aware that we have two HealthPathways teams in our PHN, one for Southeastern Sydney for people who live inside the Southeastern Sydney Local Health District, and the Sydney team, which was the OG team, for the people in the Sydney Health District. If you could go to the next slide, please. So I like to reframe HealthPathways for people. It's not just a website with guidelines, but it's actually our goal is to help people help their patients negotiate a very complex health system and make the journey easier for the patient by helping everybody practice to the top of their scope and therefore reduce unnecessary pressure in the health system. The way it looks is that it's a practical online tool which is available to all AHPRA registered health professionals used during the patient consultation. It's designed to be point of care use. Our main audience is GPs, but other primary care clinicians can also use them, like practice nurses, even pharmacists. They contain locally agreed and up-to-date information on how to assess and manage patients and how to refer them to local services. Not a guideline. It's meant to be able to be accessed and used at the point of care. Next, and it's free, whereas a lot of the other guidelines you have to pay for. Next slide. There are a few different pathway page types. You'd be familiar with clinical pathways, which are a collection of pages that provide information about the clinical presentation, and that can either be a diagnosis or a presentation. So you can have a community-acquired pneumonia pathway and you can have a chronic cough pathway as examples. And then we also have resource pathways that might be a pathway just about the medications used in a particular condition or how to do a particular examination, like the 5-minute neuro exam for a patient with possible dementia. And then you've got referral pages or request pages, which are how to request the input of another health provider to your patient's care and inviting them to be part of the team. Next page, please. We've got a new search option that's become available once people have actually established their individual login, which is another new thing that's happened to HealthPathways. So when you start searching for something in the top bar, you'll see that there's a little arrow there pointing to, oh no, my arrow is pointing to the very first option that says try Smart Search. And if you click on that try Smart Search, it's an AI enabled search of the Health Pathways site. So you can put in your search term and then it will tell you where you can find that term, and then you can select the relevant region. And next slide, please. And then that will show you where on the page you're going to find the information. So the name of the pathway and where in it. So if you click on that, it will actually just open up that part of the pathway, which, you know, makes it easier for you to find what you're looking for. We'd be very interested in people's feedback on how that function is working for them. Next slide. Just when to use Southeastern Sydney versus Sydney. It's basically where your patient is going to be accessing the service. So if they are going to be accessing the service in the Sydney Local Health District, you use the Sydney Health Pathways. And if they're going to be using it in the Southeastern Sydney Local Health District, you use the Southeastern Sydney Pathways. You can see that we've got some new cognitive impairment and dementia pathways that both teams have been working on together with working groups from both regions. And we're really hoping that that will mean that there's a bit of continuity of care for our patients across the two regions. We've been working pretty well on the cognitive impairment and dementia suite with the pathways that you can see on that slide. And we've also got some new ones coming on decision making and behavioural and psychological symptoms of dementia and behavioural disturbance in older adults. And I know it looks like they're two different things, but when we tried to combine the two pages, it got too complex because sometimes a patient's behaviour will go off because they've got delirium or something else going on. And so then that's about doing a medical assessment and looking at what else is going on. Whereas the BPSD type presentation is a different presentation, requires a different approach. So we decided to have two different pathways for that. Next slide. That's showing you what the pathways look like. So we've also got, you know, the 5-minute neurological exam and the medications used in dementia. Next slide. Okay, logins, good. So from the 2nd of December, you've had the ability to create an individual login. And the benefit for that is that there's better security. It improves your experience of the pathway, and you can reset your password. So because of the Smart Search, that actually makes it easier for you to use it. So what you need to do, and you need to do this before the 31st of March, is create your individualized login. You get instant access, and then we review the information you've given us and check that you are legit. And so if there are people who are trying to access the Health Pathways site who are just curious but not ARPA registered, then we have a way of reducing their access, but still making sure that you have access. We won't be keeping any individual information about you, so your data will be protected. One of the, there's just another slide, I think, Lauren. Oh no, go back, please. Sorry. Oh, that's the other thing I wanted to talk about, the CPD. So, sorry, next slide. The one after the, yes, that one. The other advantage of having an individual login is that you can track your CPD. So on each of the health pathways, over on the right-hand column, you can see that there's a little thing that says create a CPD report. And because all of your activity on the Health Pathways site with your individual login, you know, it can access what pathways you've used. You can then click on a thing that says create report, and it will tell you what pathways you've used and how much time you've spent on them. And then you can write a reflection if you want to, which is optional, on what you learned from the page. And then you can import it as a PDF and upload it to your log to prove that you've been doing education of yourself on the run. So if you're a HealthPathways user on a fairly frequent basis, you'll find that you'll log up the hours pretty quickly to help towards your CPD activities. I think that's the last slide, Lauren. There you go. That's just showing you more about how to use the CPD, choosing your date range, and then you can remove pathways that you don't want to have. Maybe you clicked on it, but you're only there because you're trying to find something else. So it makes it a more meaningful report. And we're really hoping that that will help people meet their requirements without too much effort, because we've done a lot of the data gathering for you. So thank you for giving me the time to present those changes in HealthPathways. And if there's any questions, I think we've got a contact our team slide at the end of that, Lauren. There you go. So if you need to contact either of the teams, there's a number of ways of doing it. You've got the email addresses of the people on our teams on that slide, and there's always the send feedback button. So there's even a generic HealthPathways web address for Southeastern Sydney. So a number of ways that you can contact us if you've got any questions or any feedback on the pathways you're using. So yeah, I think that's it. Thank you very much.
Thank you, Martina, for joining us for this session to give us this update. I understand we have permission from the HealthPathways to share those slides, so we'll be emailing it to everyone in the upcoming days. Thank you very much. And now over to our facilitator, Dr. Peter Piazza. Thank you, Peter.
Thanks very much, Lydia. It gives me great pleasure to introduce Dr. Natasha Spalding to everyone this evening. I have to say that one of my first encounters with Natasha was probably in the second quarter of 2020, when she rang me up at home at about 10 o'clock one night, telling me, "You've been classified as a close contact after your visit to residential aged care facility X, and you will need to isolate for the next 10 days. So I had to go up to my wife, who was sound asleep, and say to her, "I'm going to toss you to see whether you or I will sleep in the spare bedroom for tonight." But anyway, we've come a long way since then. And as I say, it gives me great pleasure to introduce Dr. Natasha Spalding, Senior Staff Specialist Geriatrician in Geriatric Medicine at Concord Hospital and the Medical Director of the Sydney Local Health District RACF Outreach Service. Natasha's worked as a geriatrician at Concord Hospital since 2009. She had specialty training in geriatrics and general internal medicine in the UK and held consultant geriatrician positions in Bristol in the UK before returning to Australia. She has long-term specialty interest in dementia, including in cognitive disorders clinics and specialist behavioural medical units for BPSD management, both in the UK and in Concord here in Sydney. She's been the Sydney Local Health District RACF Outreach Medical Director since 2018, and I can say what a great service that outreach provides. So without further ado, I'd like to hand over to you, Natasha, to present on advancing dementia diagnosis. Thank you.
I'm technologically challenged because I don't have access to my fancy devices, so it's on my laptop. To me, it's in in presentation mode, but I understand that you can still see my slides on the left, and I'm sorry, I don't think I can do anything about that. I feel somewhat of a fraud presenting this because although I have worked in dementia for a very long time, particularly over COVID, my main focus has been in residential aged care. So I do want to acknowledge the Aboriginal people on the lands in which we're meeting. For me, it's the people of the Wongal people of the Great Eora Nation, and very nice land that we have too. Peter, I did also want to say I'm happy to take questions in the midst of my talk, so please just butt in and I'll halt and we can deal with those. I'm very happy to do that. Okay. So this is the beautiful Wongal land on which I sit. This is You can see Concord Hospital with a very smart redevelopment there, the Rusty Priest building. So I don't know whether you can see my pointer, but these three sort of fingers that come out towards the helipad are our new building. And I will be eternally grateful to and Timson General Manager when this redevelopment went through, because you can see the very beautiful curves that we have mimicking the old Art Deco features of Concord Hospital. And it's a very fine building to work in. And I have to say, I've not been in a private hospital that surpasses the facilities that I now enjoy. So on this bottom left picture, the sort of white that goes down with blue stripe, that's our clinic room. And if you look at this furthest finger to the right, that's where our dementia ward is. So just briefly, that's the beautiful Concord building. Very nice. So in terms of me, I thought I'd just let you know a little bit of irony, I guess. So I came to medical school, old-fashioned 6-year degree from a neuroscience background, and I was wondering whether I was going to do geriatrics and neurology, but I really thought that at the time that, you know, as a neurologist, I was going to make fancy diagnoses, but I really couldn't do anything for any patients, and that didn't suit me. So I decided I would approach geriatrics, and of course, the greatest irony of all is that the condition that I've spent my working life in, actually, I don't have any major treatments for, but I believed absolutely when I started as a registrar back in 2003 that we were really just on the cusp and I would have effective pharmacological therapies very quickly. And when our new building went in 2022, we have PET scanner there, which is waiting patiently to be used for tracer investigations when we do have effective agents. I'm not sure that's going to happen in my working career now. I'm more than 25 years. How many years will I have to wait for effective treatment? I don't know. But we are able to provide really good quality care, and we do have pharmacological interventions for symptoms. So I would say I chose a Cinderella specialty, and then I chose the Cinderella subspecialty, but really it's being transformed at the moment because you can see the very high prevalence of dementia, but you also see that represented in cause of death. So for Australia now, dementia is the leading cause of death for women and second leading cause of death for men. So these were some of the things that I thought I would talk about. I talk about some imaging techniques, some innovations in plasma and CSF testing for dementia. Think about pathways and destinations, and what a cognitive disorder clinic or memory clinic can offer. What helps me in my diagnosis? What would I want if I was approaching somebody with cognitive issues? And I think what do they need? What do patients and carers need long term? And then navigating some safety issues. So first of all, to imaging, although the guidelines say that imaging is not required for patients, I think that's very hard to justify in 2025. I think there are many structural abnormalities that are treatable, and I think you really do need to do at least one structural imaging in somebody's journey. And you know, we will mix, or I will mix my approach either from a CT with coronal views. I think the coronal views are very important. They used to be unusual, but they come pretty standard with all CTs now. And obviously the MRI gives me a lot more detail, but there are negatives to the MRI in terms of exclusions. It's a longer scan time, and you know, it's much more expensive than a CT scan, but it's much better at vascular pathology, and you get better view of the pattern of atrophy when you're trying to make a determination of what the cause of the dementia is. And with machine learning and such, the volumetric MRIs are getting better and better. You have to remember, though, that you know, an individual's change over time is quite small, so only about 2% per annum. So you will see some neurologists doing frequent repeat scanning, which I think is unnecessary and is wasting our tax dollars. And there's certainly very impressive Tesla increases for MRI scanning. But at a minimum, I think you need a CT scan. The MRIs are really changing. So if you know, started out in medicine quite a long time ago, you're probably on you thought a 1.5 Tesla MRI was absolutely fantastic. Now most places will be scanning on a 3 Tesla MRI scanner. And we do have 7 Tesla scanners in Sydney. They're for research purposes. So at Sydney Uni, there's one in the Brain and Mind and one at Charles Perkins. I tried to look to see whether there was something in the eastern suburbs. I couldn't see one clearly identified in the UNSW stuff, but it may well be there. I would be surprised if it wasn't there. And then we really have just recently 11.7 Tesla. That's the French Atomic Agency, and that's incredible. That's really looking a bit like a pathological slide. And if you look at a 7 Tesla even at the hippocampus, you're getting very, very good differentiation between the layers in the brain. It really is astounding. And you wonder how this will transform pathology testing in the future. And of course, we are looking very carefully at the hippocampus always when we're looking at dementia. It's the classical place for atrophy for Alzheimer's disease, and that's the benefit of a CT scan with coronal views, because this is what I want to have a look at. How much CSF have I got around there? The 11.7 Tesla, I don't think we'll ever see that in clinical practice, but I do really expect to see 7 Tesla come through. The 11.7, you need this massive room-sized magnet to actually power those images. So I would use MRI scanning in younger people. I think that's valuable in terms of vascular pathology and also autoimmune stuff. But in an older person who very clearly looks like they have Alzheimer's, quite frail, I'll just do a CT scan. You will know that there's now MBS reimbursement for 18F FD PET. It's been a technique that's been around for a very long time, 1970s. Glucose analog, so it's really telling you about functional parts of the brain, how it's lighting up, which parts of your brain are actually being utilized, and again the stereotactic machine learning and ease of putting the scans into an anatomic standardization has really, I guess, assisted with this. I don't use this routinely because most of the patients that are referred to me are older, and in fact, I haven't ordered one since our scanner arrived. But I have done so previously with select young onset patients. But the neurologist would be using this quite a bit. It is actually interesting because if you look at MBS, the FTG PET is the only imaging study that's actually specifically for a dementia. All of those other scans, there's nothing that says it has to be for dementia. It's really about excluding other pathology. And these were pretty awful when I started, but getting much, much better in terms of differentiating what type of dementia you have in terms of where your FTG activity is. So it is much better than it was, but how much does it really add to your clinical assessment? I would say for the majority of older people, for the majority of dementia patients, it's not that helpful. But of course, there's specific parts of the brain which are classically associated with particular dementias. And that's the MBS for FDG PET. So not a cheap test either, not a long test though. So I guess that is one of the advantages. And then, of course, really the exciting bits about PET scanners and I think where we will end up going is really about protein-specific traces. So amyloid PET has been around a long time. We're approaching 15, maybe 20 years actually, with amyloid PET. Tau PET has coming through. You've got dopaminergic, you've got TDP43, there's microglial traces now. And I think this is going to be more exciting in terms of trying to pull out what pathology you have, if in the event that we actually have a monoclonal antibody which will target these specific proteinopathies or changes in the brain. But it's not going to be useful unless we have effective treatments. Peter, are there any questions for the imaging?
I think there is one question, which I'll read for you. It says, what are your suggestions for diagnosing dementia in patients with intellectual disability who cannot tolerate imaging? These people might need to be fully sedated for a scan, which is not really practical. Can we diagnose without imaging?
Yeah, absolutely. I don't think it's you know, an essential requirement in that circumstance. And really, you know, you're looking at intellectual disability. What is, have they had any testing before? And if they're severe, not able to even manage a CT scan, then I'm not sure, you know, why we're worrying too much. I mean, you know that as somebody ages, if they have any kind of intellectual disability, it's going to get worse. So, you know, you're then in a situation where you're saying dementia superimposed on intellectual disability. But a CT scan is really quick. It is a really fast acquisition now. So long as you can lie on the bed just for a couple of minutes, we can get images via CT. But the intellectual disability wouldn't be worrying about at all.
Okay, thank you.
Then some changes, I guess, with biomarkers, and one of the reasons really for looking at these is we need something cheaper than doing multiple PET images. So, you know, private scan for a PET image, you might pay $2,000, $2,500. That's a lot if you're going to think about an amyloid, a tau, a TDP, all of these things together. It's you know, it's very expensive. So can we actually manage with other biomarkers? And there's a lot of work going on in the space. So plasma biomarkers obviously have significant advantages, and they're commercially available already in the States. The problem is that we don't really know how valuable they are. And we certainly don't know that for people who have complex disease like older people. So they might be useful for young onset dementia, but not in the typical patient that you're going to see. You see, there's a whole range of different biomarkers that are being used. And every time I go to a dementia conference, it's slightly different. And this is the preferred one. And the next year, it's something else, and we've moved on. But there is progression, and p-tau217 looks like it really is the lead plasma marker. Tau correlates better with atrophy and actually correlates better with clinical disease and Alzheimer's disease. So it makes sense that it's not an amyloid marker, because you have the amyloid change very early, but it's not. It doesn't correlate with clinical deterioration. So this is looking good. p-tau181 had a bit of sunshine in the day, and now we're moving on to p-tau217. as I said, there's a lot of commercially available plasma screening tests. This is really going to tell us the answer, though. So in January this year, the first dementia patients in the UK were put into, there's 2 trials actually, one run out of Oxford and one University College London, and they're working together to look at plasma biomarkers in the real world. So far, mostly been done in those very highly specialised neurology research clinics rather than in the sort of general dementia patients. So my money's on this. I'm not getting excited about plasma biomarkers until this delivers or not. So I'm going to have to wait about 5 years, but it's underway, and that it is exciting. Am I ordering any plasma biomarkers? No, and I don't believe that you can access them currently in Australia outside of a research program. Peter, is there any questions for plasma biomarkers?
No questions about that at the moment, Natasha. So I just remind everyone that, as Natasha said, she's happy to take questions now, or we will have Q&A at the end of Natasha's talk.
Thank you. And then CSF. So this is at Concord. So we've known for a long time, or we've been mapping for a very long time, the CSF and changes in the CSF as people progress through Alzheimer's. And if you look over here, the so the amyloid beta 4240 is basically the first marker that's up and running. And so if you've got an early patient and you're thinking about whether they should enter one of the clinical trials, or if you're in the US, somebody who's going to go on an amyloid monoclonal antibody, then you can actually use CSF biomarker instead of a PET imaging to confirm the presence of amyloid. And just noting, you're probably fully aware of the amyloid cascade hypothesis, that we're really not sure is what happens in standard Alzheimer's disease. It certainly is what happens in the genetic forms of Alzheimer's with the amyloid precursor protein and with the pre-senilin dominantly inherited diseases, where you can see aggregation of amyloid 20 years before you actually start to have symptoms. So that's the reason for it. And Margaret Jenu, who some of you may well know, in our laboratory here, went ahead, and we have Roche machine, and so you can actually request a CSF amyloid and tau. It's about $400 cost. I have yet to use it because, again, if I don't have something that's going to treat it, I'm not sure what the value is. But certainly my colleagues in the neurology dementia clinic at PA, many of them will go ahead and have CSF. When I worked in the UK, we routinely did lumbar punctures on our dementia patients. I can tell you from spending hours in our outpatient service, getting dyspraxic people onto a bed or sitting up, and still it's incredibly difficult. I would not want to be relying on CSF biomarkers. And when you look at the studies, it's always shocking to me how small the numbers are that have gone ahead with CSF. People are happy to have PET imaging, happy to give as much blood as they like, as you want, but they don't want to give their CSF. All right. Any questions, Peter?
No questions yet.
Okay, fantastic. So this is what I actually think is more important than those fancy imaging techniques, or in fact the biomarkers. This is what helps me differentiate between dementias. And it's detailed neuropsychology assessment. It's not cognitive screening. So the screening test that we'll use, I would use a RUDAS. I use RUDAS commonly at the Redfern AMS. I do a cognition clinic there once a month. I've never had reason to use the kicker. Most of the people that I see at Redfern AMS have a higher level of education than the Mediterranean migrants who are in their 80s and 90s now. So I would use a RUDAS. I use an Addenbrooke's cognitive examination, so that's out of 100, and that gives me lots of different types of domains when you're testing, and helps you to differentiate between vascular and Alzheimer's disease. And of course, embedded within that is an MMSE, which I think is useful because the majority of doctors can use the MMSE as a gauge of how severe somebody is. So doctors generally understand what a 5 out of 30 looks like, what a 10 out of 30, what a 15, what a 20, what a 25 out of 30 looks like. It's not a great test because it doesn't pick up those frontal lobe components, but it's a good gauge. And then I would always use a clock drawing test in addition. So those are the screening tests. But really, after my screening test can often be wrong, or at least there's much more information that can be gained through neuropsychology assessment. And I understand. I'm sitting in, Ivory Tower Public Hospital, where I have access to neuropsychology assessments. We have part-time, but we have 4 neuropsychologists who work in cognition here. But it really does, it's the thing that helps me the most in making or refining diagnosis. Not is it or isn't, but what type is it. And that's important too, because if you're a very bright person, very high functioning cognitively previously, you're going to be up at the ceiling of my screening tests. And so taking somebody to really the point where they can no longer manage the test, that's what the neuropsychology assessment does. So it's very difficult. You will always go to the point that you can no longer function. And the kinds of things that they'll look at, or that they will look at, they'll make an estimation of your IQ. That obviously helps in working out where you're sitting on a scale. So we'll do basic IQ estimation. We'll also then have a look at what your lifetime performance is. So what kind of education level did you achieve? What sort of employment did you have? What were your responsibilities in that job, to try and help us work out where you should sit pre-morbidly, and then obviously review that. Because somebody who is performing in the average range but has been extremely competent or bright before, that's obviously going to be a change, but for others there'll just be, there's no change for them, they're completely stable. So attention is really important. It helps with frontocortical issues, and it's really important in vascular disease, in extrapyramidal syndromes, memory, and you can differentiate between the learning and then rapid forgetting, and then assistance of cueing, which suggests inefficiency in your brain. We do quite a lot of language tests, particularly for those more sort of specialised language dominant dementias, such as primary progressive aphasia or semantic dementia. And executive function is obviously critical. Visual spatial body disease and disease as well. And then also looking at mood and behavioural and social issues, and putting all of those things together. So they're quite complex, and you're not meant to read this, but there's lots of different tests which will push you, or results which will push you, your diagnosis into the different subtypes of dementia. And you can also see that neuropsychology assessment is useful when you're coming early for assessment, and I will be able to give you an estimate of what the type is. But if you come to us much later, an advanced stage, then you'll see that actually everybody tends to deteriorate, and working out what the type is near impossible. So you can see here in the black bars, that's early stage disease. So in this study, they were primary progressive aphasia and behavioural variant FTD, and then Alzheimer's. So quite different patterns in neuropsychology testing early on. I find it incredibly helpful, and I will, like, it's not infrequent where the neuropsychology picks up something that I was not expecting, but really because I haven't been able to test it. So I find them very valuable.
Natasha,
Peter,
before
any
we leave
questions?
neuropsychology, then this is a comment rather than a question, but the comment is that it's very difficult to access neuropsychological assessment in the public system. Could you comment on that and give any suggestions as to what might be the best way of accessing?
So I'm a little surprised to hear that. So it's not possible for somebody to refer directly to a neuropsychologist from outside and just have that report. They all go through a clinic so that there is additional assessment, particularly in relation to the outcomes of those testing, and I guess feeling long term that you need both the clinical review and the neuropsychology assessment together, so that multidisciplinary approach. But if you've got somebody where this matters or you're concerned about them, then you should refer to a public sector cognition clinic, southeastern Sydney, but Sydney, there are cognition clinics at Concord, quite large clinics, and at Royal Prince Alfred, led by Rebecca, one of the neurologists, but it has it has geriatricians there too, and dedicated neuropsychology attached to it. So for us, in terms of the wait list, you're probably looking at about 2 to 3 months, 3 months to get in. I wouldn't have considered that excessive.
Okay,
I think, to be honest, we're going to need more neuropsychologists.
Yeah, there's a comment that in the St George area it can take up to 6 months.
I'm sorry?
There's a comment that in the St George area it can take up to 6 months to get a neuropsychology assessment.
Oh, they should get on to Pigonski.
I
think this is much. I think that this needs to grow. I absolutely believe that neuropsychology is something that we need to invest in with our increased dementia.
There's another question here about a topic which I think is the bane of most GPs' lives when they're doing this. The question states, do you have suggestions on how to determine if patients with mild dementia / mild cognitive impairment are safe to drive when doing the over 75 driving assessment? Is there a test that is most accurate? And MMSE, RUDAS, fail marking maze tests are mentioned there. And is there a cutoff score that you would suggest is not safe for driving, in particular with an MMSE?
Are you talking about driving or to give a diagnosis?
No, the question is purely about driving in over 75-year-olds.
Oh, yeah, very, very difficult. Extremely difficult. If you can't draw a clock, you're out from my perspective. So the trick with a clock drawing exercise is to give them a full A4 piece of paper and ask them to draw a big clock that takes up all of the page. And the reason for that is you need to have the numbers spaced, and you need to be able to plan that. As soon as you start putting them in the top corner, it doesn't work. Or if you let them draw a really tiny, 7 centimeter clock, then often just by putting the numbers in, they'll make the spacing correct. So always a really big one. So if you can't space, you can't set the time, then I'm sending you for a driving assessment straight away. There is no test, there's no score on the MMSE that helps you. The things that you really want to look out for, those visual spatial things. So if somebody is still driving, I'll do a clock, I'll do pentagons, and I'll also do the wire cube. So you've got 3 different sort of visual spatial planning things. Also very interested in attention. So very basic on mini mental in terms of the serial 7s and world backwards. I get them to do both of them every time I do an MMSE. So if you've also got issues with attention, that's a major, major flag. If you're sitting at 15, I'm deeply concerned. The 15 to the sort of 20 range is a little bit complex. It depends on the person and what they have. I will always ask them about so points lost on their license, accident, dings to the car with parking and lane placement, and we'll try to, and we'll ask whoever's there to providing the sort of collateral history. And do they feel safe having a child travel with this person? I have very, very low threshold for referring for RMS on-road assessment. It's impossible for you to actually test on a paper-based test. So there's some, there are a number of different sort of online tests. They're not great. It's really, you have to get them in the car. If they've got significant dyspraxia, if they've got issues turning, all of those things, I'm pushing towards, let's do a test. Let's get you in the car on the road and let's see, not me. RMS or obviously an occupational driving assessment is really expensive. And if they fail the RMS tests twice, I say, this is enough, please don't do that again. But often RMS allows them to go for a 3rd time. I've seen terrible, terrible things with driving. I think we all have to be very careful about this.
Okay. There's a request.
Is there anything else?
There's a request for the contact details of the neuropsychology clinic in St George Hospital. I don't know what the answer to
Sorry, I can't help.
To that is, but I'm sure if you were to call the hospital, they should be able to find the neuropsychology clinic for you.
And possibly HealthPathways as well might have contacts.
Yes, that's another suggestion. Thank you, Lydia.
I'm just checking, Lydia, and I'll post in the chat for you to pass on.
Thank you, Martina. Teamwork.
And if you are referring privately, I would be looking for a place that has a neuropsychologist as part of their team, which is happening more and more.
Okay. All right, let's keep going.
All right. Okay. So what would I want? I've had a look at it. I had never looked at the Southeastern Health Pathway before giving this talk. But what would I want for myself or my family? I would definitely be looking for a place that has MDT practice. I think it's valuable in keeping people grounded and accepting of other perspectives. I think that's really important. So group neurology or geriatric practice that meet and discuss, and those that have other health professionals involved is really important. I have to say, I would want an MRI brain. Yeah. I would definitely want an MRI of my brain if I was attending, and I would definitely want neuropsychology assessment. But I wouldn't send somebody to neuropsychology assessment if they're not capable of doing an Addenbrooke's test well, because then there's no value. If I had rapidly progressive dementia, then I would really want a lumbar puncture. And the reason for that is to exclude an autoimmune encephalitis. And there's a huge explosion, as you will well know, in autoimmune encephalitis. And those are the dementias that are, readily treatable, but you have to get in fast, and you need to be aggressive with them. So I would be presenting my back in that situation, but not in something else. And if I was early onset, I may consider a PET scan, but I wouldn't be quite sure how that would help. For those in Sydney, there is a new dementia framework and roadmap, which has been released and is on the website. And this is the aim, our vision rather, so that we will provide timely, responsive and flexible evidence-based healthcare to all people. And healthcare will be continuous, tailored to meet individual needs of the person with dementia and their broader social and cultural supports, and maximise their quality of life for all. So very, lofty and admirable. And these are the kinds of things that are important. So I dislike a diagnosis and discharge. I think that's really difficult for people. I am very happy when GPs feel able to spend all the time that's required with these people, and very happy to do shared care kind of model. But I think at least in that first phase, you ought to be seeing them again, and really you should be at least offering them a yearly appointment until you're sure that there's stability of their disease and there's not going to be a significant change. The things that I can offer also relate to early planning, which you can do too, early planning in terms of supports with My Aged Care. But there are other things. So we have a dementia occupational therapist who works with our service, who can go out, look at behavioural issues, so not just the physical care requirements, but also how you the complexity of having somebody who no longer has a memory and needs all of those supports. How do you manage that yourself? What kind of tricks can you put in the environment to help? How can you make their day interesting and meaningful to the patient, the person who's living with dementia? So quality of life, really important. I think forward planning, important. So getting to the point where you're going to put limits of care in place. Hospital's okay, but just a general medical ward. We're not going to go to ICU. We're not going to intubate. All of those sorts of things I think are really important. And also being able to predict what's going to happen. And that's the real advantage of knowing the type of dementia. So it protects you in terms of what medicines I might want to avoid, or which ones I think are reasonable in this circumstance, but also what is normal for somebody who has Lewy body dementia or somebody who has semantic dementia, and what are the dragons ahead? What are the things that are going to happen that might be particular to this person? So I think opportunities to come in and out of care or to stay in care long term is really important. And for me, I will see most people will end up about 7 years in my clinic. Not everybody will do that. Some of them will be like 3 or 4, and then 7 will be quite common. Now that I'm working in residential aged care, I often see right from the beginning MCI or maybe subjective cognitive impairment, right through maybe needing Ward 17 for behavioural management, and then palliative care, either wherever that might be, home, facility, or sometimes on a ward.
Natasha, sorry to interrupt again, but you have your audio has been breaking up at times, and everyone hasn't been able to hear exactly everything that you've said. But there's a question here that the attendee thought that you might have mentioned something called a YQ test. Is that correct?
A wire cube, so just a 3-dimensional cube.
A wire cube, okay. All right.
Yeah, it's just what it's called. But if you look at the RUDAS, it has a cube in it, and that's what I'd be looking at. So I'd pull out the intersecting pentagons, I'd pull out the cube, and I'd do a clock.
Okay. Thank you.
I'm sorry about the audio. I don't seem to have connection issues here. And then as part of our healthcare framework and roadmap, we do have a website. So if you want to go onto Sydney Local Health District and search dementia, it will come up, and it's got diagnosing dementia, and it's got a whole lot of supports and various other things in place. And the plan is to have a dementia hub where people can come into from any part of the community, be referred on or not as needed, and just have a space where people can come to. I think, I think it's really important to focus on this is a chronic disease, and that's what I always say to people. You have a chronic disease. You could have had diabetes. You could have had emphysema. You could have had, peripheral vascular disease or ischemic heart disease. You've got dementia. This is living with dementia for a period of time. How are we going to do that? We want you to live as well as you possibly can. We need to put supports in place to minimize the disability that you might develop as a consequence of that dementia. So safety is really important. And when you first start out, finances is the most important thing to think about and sort out. Does the person have enduring power of attorney? How are they? Are they self-funded and managing their own superannuation? All of those sorts of things are critical, and they're the first problems that people will run into. And of course, scams and such are a real issue for older people with cognitive impairment. Then will come driving, and we've spoken about that a bit already. And then you have cooking. And you really want to be having safety switches on. You want to have carbon monoxide monitors in addition to smoke detectors. And you may want to isolate the stove completely or remove it. And then also about security. The one that follows the cooking will be, are you locking the door? Is your environment secure? Can you manage going out into, the street and such in a safe manner? And carer support is really important. So practical daily living, assisting with personal care and those sort of things. But then respite, really valuable, both day centre and such, and residential respite, and a lot of counselling. So we have a psychologist in our team as well who will take on people who are really struggling. And there's obviously Dementia Australia. There's various different counselling options, but it is absolutely critical. And I had a terrible case a few years ago where a very devoted son ended up taping his mother's mouth when he was really frustrated with her calling out overnight. And he had done the most incredible job. And of course, there was police involvement and court and the whole shebang. And you just never want, you really want to be able to support these people as much as possible. So if you're sitting in my clinic, I will be saying to you, if you can't manage, you need to call so that we can at least do something. You can take into hospital if required, while we work out where you're going to go from there. And if we can't do a direct toward admission, then you need to come to the emergency department, because I don't want to be in a situation where you have this really dedicated carer who snaps and does something that they will regret and will destroy a family for a long period of time. Always got to think about toxins. A lot of people drink more than you think. There's a lot of cannabis use as well. That's important to consider, both medicinal and other. And then thinking about healthy lifestyle for everybody. So physical activity, meaningful activity, and making sure that you're managing the rest of their health care. And obviously, I'm going to say preventative health is really important, including their vaccinations. And I would say the biggest risk for COVID at the moment, it's twofold, but the biggest one is a delirium. where you will not recover from that, or you will fall and fracture something. And then after that delirium is the risk of thrombotic events, which obviously can still continue for a long period of time. So for the older people, it's about their brain that they're getting vaccinated, really, rather than their chest at the moment. And palliative care, introducing that palliative care approach at the right time is tricky. But again, I think is important. And I would say holding somebody's hand through end-of-life care is vital and will make it a much better process for everybody. And I kind of like this Dementia New Zealand roadmap because you can see all the red flags and problems that are going to come along the way. But this is pretty accurate, actually, in representing somebody's journey. And then for a number of years now, the Lancet Commission has looked at risk factors for dementia, and we've had 2017, 2020, and now 2024 iteration. And at the moment, you can see that actually the risk from smoking is reduced. That's good because we have fewer people who have smoked, but there's still things here that you can act on. So hearing loss, not clear that correcting it makes a big difference, but it is going to make your world a little bit better. I understand the complexities of hearing aids not being easy to manage for some people with dementia, but if you can, that's good, and I anticipate the technology there will improve quite rapidly. It already has, but I think there's further progress there. It's vision, and then it's about social inclusion and doing things and managing their vascular risk factors. Any questions on that?
Look, there's a question that's still outstanding in my mind anyway about driving, because someone asks the question, can patients with dementia, and I suppose it depends on the degree, be given a restricted licence for quality of life and independence? And they're suggesting, say, 20 kilometres from home during daylight hours. What's your approach to restricting driving? Is it an all or none?
So I think that if you consider them not to be safe, I don't think that restriction is helpful.
Right.
So I don't do that. And I think it's a fault in our system that you can select that. I think if you have any concern, they need to go to have an on-road test. Because there's no evidence that in the daylight it would be better, particularly because it's not about vision. It's about how you approach an emergency situation or a change. And so and most of the accidents that you have for people with dementia are during the day because they're not driving at night anyway. Obviously, local area, they will know that. But, you're talking in Sydney at the moment. Sydney is a really challenging place to have anybody, particularly in our areas. I would not feel confident about restricting their restriction rather than stopping. I'd send them and let them try on the road and see.
Okay, thank you.
The deaths, the multiple people who have gone down the freeway the wrong way, the deaths that I've seen they're all in driving.
And most accidents tend to happen closer to home anyway, don't they?
Got fatigue ones, yes. Yeah. So my final thing was about MABs and just talking about the complexity of dementia in older people. So the idea that, an amyloid specific is just going to target the amyloid is going to solve your dementia is a little bit fanciful, I have to say, because there's so many components. There's neuroinflammation, there's oxidative stress, there's vascular changes, there's loss of brain tissue. So it's a very complex system that you're talking about. Just doing one single thing, unlikely to help, and it hasn't. These slides I've pinched from Richard Lindley. We did a symposium together a couple of years ago, so they're definitely his slides. This was really looking at, if you look at older people and you look at the neuropathology, you can see that a lot of people will have a huge load of neuropathology, but actually be functioning okay. So in this case of the religious order study and Rush Memory and Aging Project, more than half had pathology, but didn't have any signs of dementia. So it's not a good correlate, really. And they also had, although they had disease that looked like Alzheimer's disease, when you looked at their pathology, range of different things that they saw on the slides. And this is another example looking at pathology in a cohort and showing that people who perform in the section here still are holding or have a lot of Alzheimer's type neuropathology. There's a lot of vascular disease there, and there's other things in the background too. And in 2023, they put together a number of different pathology cohorts, again looking at who has dementia, what do their brains look like. And you can see, if you have just on the left-hand side, if you have one single pathology, then you're more likely to have no dementia than have dementia. And it's only when you're getting up to this side, where you've got a lot of complex pathology, that almost everybody has dementia. So if you scan somebody and they've got amyloid or tau, where are they sitting? I'm not sure. I'm not sure whether they're in the blue or in the orange. We also know that that actually the incidence of dementia is reduced. And so our later populations, it's less for them. And that's a whole range of things. That's going to be nutrition, it's going to be schooling, very important education. So they're going to change over time. So and then we also know that the more frail part, so the other pathology that you hold, that interacts with your actual disease process, and somebody who has a lot of frailty, you can significantly increase the likelihood of having advanced or severe dementia in that circumstance. So there is an interaction, and really saying that what we see in people is not what we see in young people. Alzheimer, his first patient is a 50-year-old woman. It's not the kind of people that we see for dementia. And at Concord here, John Cullen and Louise Waite and Richard did a little paper in 2019, really saying that as you get older, you're more likely to have a lot of different pathologies and not the standard. And quickly on the maps, I'm just going to jump ahead. This is Clifford Jack's work, really looking at the biomarker change that you can see in people who are known to have genetic forms of dementia, Alzheimer's disease, where you can actually track the autosomal dominant person and look at them prior to their actual onset of dementia. And you can see those biomarkers come through. And there's a big Chinese study that has also this year, which really saying 17 years before you start to get your Alzheimer's disease, you can see amyloid changes in the brain. And when we look at the monoclonal antibodies, just to talk quickly about donanemab, that was 18 months of treatment in people who had mild disease. And over those 18 months, every fortnight, they needed to go and have an infusion. the MMSE difference between those who were on the active arm and those who were on placebo was less than 1 point. So yeah, okay, statistically that looks good, but I couldn't tell the difference between somebody like that in my clinic. I wouldn't notice it. So I wouldn't have said this person's improved dramatically. And Roger Dampney, who is actually a cardiovascular physiologist, wrote this reply in relation to the donanemab study, really showing there's a huge amount of scatter between those people who are on placebo and those who were on donanemab. And A relates to those who had a lot of disease, pathology, and C in those that were mild. So there really is not a big difference in these groups. And the fact that we don't have it registered in Australia and people aren't going to have access to a treatment that costs $50,000 US a year and requires a huge amount of infrastructure for a tiny benefit in cognition, I don't think that's a bad thing. So Peter, I didn't have anything else, and I can see I'm already a lot of time, so very happy to take other questions.
Yeah, I have some questions myself, and there's some questions from our viewing audience. There's two questions here that sort of one runs into the other in a way, because the question is, do you think any of the current medications available for dementia have a significant impact on disease progression or patient quality of life? In other words, do you think that they're worthwhile? And then following that is, if any of them is worthwhile, how do you decide if someone is eligible for drug therapy such as rivastigmine or donepezil, and how do you decide which drug to use, if any?
So I think there's marginal symptomatic benefit from all of the cholinesterase inhibitors. I don't think that there really is a preference of one over the other. So I think you can choose whatever you like, basically. In terms of efficacy, obviously, really, I believe very strongly, really, Alzheimer's is the thing that you're going to target. I don't think, well, there's evidence that doesn't work well in vascular disease. And so you're talking about most of 30% of people who you try the medication on are going to have some benefit. There are a very small number who seem to get quite benefit. So if you've got somebody who is functioning quite well, but does have and doesn't have side effects, isn't at risk of side effects, then I will start it. And I ask about 30% to stop because of new onset continence. It causes cardiac conduction abnormalities, so I always do an ECG before I start a cholinesterase inhibitor, and looking, to see whether I need to think about doing an echo and a Holter. And I also warn them about the significant gastrointestinal side effects, which do tend to settle down, but are there in the early phase. So I will try quite a lot of people on treatment, but not if they're particularly frail, not if they've already got incontinence. And you also need to be giving it consistently. And you need to tell them that if it works, it's going to work for a couple of years, and then it's going to stop. So it's not a wonder drug. It's just going to hold them steady for a period, and then they're going to catch up to their previous trajectory. So do use them, but don't consider them wonder drugs. Sorry, the rivastigmine. All right. So this wonder whether this is better in Lewy body and such. I don't believe so. Rivastigmine is a very difficult drug to take orally. It causes a lot of GI symptoms. I don't tend to use it, I have to say myself, and I don't believe that cholinesterase inhibitors really make a big difference in terms of behavioural symptoms. They can agitate people, and so I will often stop them when it develops behavioural symptoms.
Okay. There's a question about Suvenaid that I was going to ask myself. I'm sure I've seen TV ads for Suvenaid. Anyway, our audience member asks about your thoughts on Suvenaid and dementia prevention or delay, and if you have a positive attitude towards it, at what age should one consider starting to use it?
So NHMRC have said that it doesn't work. I think the statistical tests that we use to show benefit are extremely concerning, and I don't believe it works. It's up to somebody whether they are prepared to spend the money. But it's very hard to understand why a nutritional drink that helps you grow nerves is really going to make a difference. If you're eating a sensible diet, you don't need anything else.
It's roughly about $5 a day, is it not? I know that one of your colleagues in Melbourne is very keen on it, but he seems to be in a minority.
He's very keen on every medication, Peter.
Okay. I have another question here from a participant. Could you comment on the effects of sarcopenia for the development of dementia? And does improvement in sarcopenia have any benefit for dementia?
So that's that complex interaction with frailty. So yes, it will make it worse. The question is, can you get them back from that? It's very hard for people to participate as they progress in formal exercise. They don't have the capacity to understand what somebody's saying. They need often hands-on assistance to complete the task. So that kind of intensive physical intervention is problematic. The biggest gain would be if you stop them from getting that sarcopenia in the first place and you enroll them. I mean, there's thousands of exercise physiologists that have been trained recently, and they're sitting around all those gyms, and there's lots of older people's gyms. That's where people need to go, and they need to start early, and they need to stay in that.
Okay. Could I remind our audience that we do have 10 minutes or so still free to answer questions, so still keep putting them through, please. I have another question for you, Natasha. Could you comment on hearing loss and dementia?
Yeah, so hearing loss is one of the risk factors for dementia. It's changed, so it was about 7%. There are some studies where people have attempted to correct hearing and show a improvement or stabilization. That hasn't worked as well. I do think that any kind of sensory loss will affect you, so you'll get reduced inputs into your brain. The issue with the hearing aids is that you often get just amplification of everything, and so it's actually harder for somebody to manage in the environment. So again, I think early intervention is important if you can.
Okay. What about length of treatment with cholinesterase inhibitors? So should we stop patients who've been on cholinesterase inhibitors for a long time, whatever a long time might be?
Yeah, this is a hard one. There are definitely a proportion of people who deteriorate when you stop them. So my view on this is, if you've had a response, so I will generally, if I'm trialing them, put somebody on, I'll get them back for 3 or 4 months. I'll do retesting of cognitive screening, see whether the family think that there's any benefit, see whether there's any side effects. If there hasn't been any benefit, certainly if there's side effects, they're gone. Don't continue them. But then if they have responded, I will leave them on until you get to the point where you're running and so gait or continence, or you can manage at home, and then I'm keen to wean, but I would always wean. I wouldn't just stop. I would drop the dose by half and then step down. For them, it's probably about 5% that you run into trouble when you stop them. For most people, it's irrelevant. But I will leave them on for years if they've had benefit.
Mm-hmm. And could I just ask, despite what you've said about imaging, blood tests, CSF analysis, etc. Would it be fair to say that the diagnosis of dementia is still very much a clinical diagnosis?
Oh, absolutely. Absolutely. I think the structural imaging is really to rule things out rather than rule things in, rules them in a bit, not a lot. I think the neuropsychology testing it's clinical, and it's actually testing how your brain functions. And it's the only way that we can really do that. But yes, it's absolutely a clinical decision. And when you go to meetings in relation to dementia, the pathologists are different to the radiologists, are different to the clinicians, are different to the biomarker, the plasma and CSF biomarker. There's a different view of what these clinical entities are in each of those disciplines. It's quite fascinating. We haven't really come together yet.
Mm-hmm. We've talked about dementia as a sort of single diagnosis, but obviously we know that there are many different types. There's a question here about, would you be able to summarise the most reliable early diagnostic markers for differentiating between the types of dementia?
I'm going to say neuropsychology testing. Because they're all clinical diagnoses, and the differences are really about how you function, how your brain functions. So that's it. If you're not going to do neuropsychology, then I think using a more detailed screening test such as the Addenbrooke's, which gives you, memory, more detailed language, visual, spatial skills, fluency, semantic fluencies and such, that's going to help you the most.
Okay. There's a comment here that the new AI-assisted hearing aids seem to be promising to avoid background noise interference. I wonder what the cost of those is going to be. Do you have anything to say about that, Natasha?
No, I don't know. I definitely think the technology will improve. I mean, there are a lot of people who will tell me that their hearing aids are $9,000. It's an expensive game, and they're very easy to lose.
Yep. Especially in nursing homes, very easy to lose. Yep. Okay. Do we have any more questions? Look, there's no more questions in the Q&A, and I've run out of questions myself. Are there just a few take-home messages that you would like our GPs to leave this session with?
I'd say it's a complex disease. It needs multidisciplinary involvement, and be skeptical about anybody who tells you that the single treatment is a wonder intervention. And the good medicine that you practice, that's really going to be the most important thing for these people.
A late finishing question here about advanced care directives. Do GPs have authority to sign on capacity of person to be able to decide on this?
Oh, absolutely. I think anybody who's interested can take on a capacity assessment. It is decision specific. If you're talking about somebody who has dementia, who is expressing a wish, I have low threshold for accepting that. If you don't have somebody who's a person responsible decision maker, and the person does not have a appointed guardian, then as the GP, as the care provider, you are absolutely entitled to make a decision. And you will see from us, both in clinic and in our residential aged care work, we will make a recommendation about what we think the advanced care plan should be. If it differs from the patient or the carer. So I think it's really helpful for hospital staff to know that somebody else has assessed this person and said, actually, I think no CPR is appropriate for this person. Actually, I don't think they need to go to ICU. I think we should all be documenting that stuff. It just makes it easier when disasters happen.
Something a little bit different from that is testamentary capacity. Do you have any tips for our GPs on assessing that?
Yeah, you need a lot of time. It's not an easy thing to do. And I don't know about GPs, but every geriatrician will end up in the Supreme Court in a will dispute at some time during their career. And it's not a pleasant thing to go through. So I have a cop-out because we don't do testamentary capacity, but we do assess people where their cognition is impaired. So if it's about this person doesn't have capacity and now we need to go to guardianship, then, you know, public hospital needs to be involved in that and supporting that. A testamentary capacity, you really need to have a lot of information about what the assets are, who's involved, what's happened before, and be testing against that. You should be thinking that you're going to spend a number of hours in this space. So it's not an easy thing to do. And we would, if we consider somebody possibly to have capacity, we will say we will not assess it, and it needs to go to a private practitioner to review. Neuropsychologists, private neuropsychologists also work in this space and can spend time talking to people.
That's why one of my patients has quoted $900 for a testamentary capacity assessment.
I think that's cheap, Peter.
I'll go back and tell her that. Okay. Look, I'll just have a final check. There are no further questions in the Q&A. So I think we might call an end to the session now and say, Dr. Natasha Spalding, thank you very, very much for your time and for your expertise tonight.
Pleasure. Thank you. I'm happy to be emailed questions as well if you wish.